we have any questions for Paul? There you go, Pat. There she comes. There comes Rachel with the microphone.
Thank you. Now, if public health officials are sometimes told where to spend their money by elected officials, do they run the risk of being, as you noted earlier, cast in with political forces who are increasingly trusted less? And is there a way to give public health officials the same autonomy we give medical doctors in their decision making?
Well, I think that's a very intriguing question to kind of think through. And honestly, I think that in my experience, you're right that the hazards are there, that we become identified with the political process. But quite frankly, I think part of what public health does is actually engage in that political process. I don't think we can avoid it. I think what we have to do is be able to be extremely good at doing that and not be afraid of it, and also bring the evidence, bring the science into the conversation, because ultimately it's through that political process that the community's interest and will gets expressed, and then eventually that moves into policy. So I think it is a hazard to become too partisan, but on the other hand, I think we do have to embrace the political process.
Other questions for Paul?
Hi, I'm David Trigman from the National Center for Injury Prevention and Control at the Centers for Disease Control and Prevention in Atlanta. Thank you for this excellent talk. You had mentioned there's two things limiting our life expectancy in the U.S. are motor vehicle crashes and gun violence prevention. And currently, there was a recent Health Affairs also mentioning that injury prevention, lack of injury prevention is leading to a lower life expectancy than other countries. And despite that, only about 20% of local health departments, according to NACCHO data, are invested in any way in injury prevention. This might be the case for other areas of chronic and disease prevention, but I'm wondering, what do you find are the barriers to engaging in injury prevention work at the local and state level? It is one of the lowest funded things at the local health department and state level. Why are we missing the boat on what seems to be a no-brainer?
Well, thanks. I think that the main driver is the fact that our funding in public health is primarily categorical, and that even though we definitely appreciate the funding that does come from your part of CDC, there's not enough there that's going to go out, and it's not really proportionate to the size of the problem. So I think what we really need to look at, and again, this is part of my belief. I'm not representing the foundation right at this point, but I think my belief is that we really have to look at how do we fund core and foundational services and capabilities in public health, and where do those funds come from? And driving toward what really is captured in public health accreditation, which is by doing that comprehensive community assessment and by doing the engagement process with the community across multiple sectors, then I think we will end up having the community and the community's health challenges and problems driving the things that public health is spending its money on. And I think at that point, we get to put more attention on violence and intentional and unintentional injury.
Scott?
Hey, Paul. Scott Burrows from Public Health Law Research. So I really enjoyed the talk, too, and it really shows the leadership you can bring here and the foundation can bring. I want to ask you about some of the polling stuff. Your results are really interesting. You know, Michelle Mello from our program recently had a paper in Health Affairs that showed actually strong public support for sort of new public health kinds of activities and a strong trust in both local and national public health authorities. And like across the board, I think we see this. I think the idea that public health is unpopular, people don't like the nanny state, it's just not true. They don't like everything we do, and we can do some things badly, but they really do like us. So how much of what you're thinking about what we need for the future has to do with just taking on the sort of received wisdom that public health is embattled, people don't like what we do, they're sick of the nanny state, and tell a different story? And if you think that is important, you know, what are your thoughts about how we as a community get past our silos and are not just fighting for tobacco control or not just fighting for obesity, but for, you know, getting back to this idea that as a group, we do great stuff that people like?
Well, I think that's a great point, Scott, and I do think that the polling data that are out there about prevention do shine a light on exactly what you're saying. And I guess my question is, what's holding us back? And maybe that's something we need to talk about together. Why do we feel that we're victims in this new, situation? Now, I certainly feel, having recently come from local government and dealt with cutbacks and budget losses and so on, there is certainly a sense of being besieged when you think about it from the day-to-day operational point of view. But I think this conference, and perhaps through social media and other venues, there's ways for us to step back and have more of those strategic conversations and really talk about how can we move and perhaps pivot away from this, this focus on the negative and really look at and embrace some of the positive opportunities that are out there and the public support that we do have, and mobilize that towards the kinds of things that we need to improve health in our country.
Lisa?
Thank you. Lisa Simpson, Academy Health, and also thank you, Paul, for that great talk. So in light with your last slide, the reimagining and the focus of your talk, public health, I was particularly taken by your use of the good to great, work here and the hedgehog. And I guess being an optimist at heart, this is a comment or sort of checking an assumption here. This is really an incredible time of opportunity where a lot of innovation in reimagining what public health is going to happen. Some good, some maybe not so good in terms of outcomes for the population and the health of the public. But when we talk about public health, we often, I think we imply a one model. Even our language, the 10 essential services, and here I may be a bit too provocative, but that this is what governmental public health does and will do until the end of time. And I think that this is a time where we're going to be thinking about what is the hedgehog for this community and this health department, and what is the hedgehog? Is it the same one in Missouri as it is in Nevada? And I think that PHSSR has a ton to contribute here to understanding what the right hedgehog is for which communities, and maybe redefining what is truly essential and must be governmental functions as opposed to not in the future.
I would thank you for that comment, and I appreciate you kind of building out some of my themes there. I do think, and really the point of this is that we do need to rethink our model, and we're in a changed environment, and so what exactly is it that is the particular, what's the sinks and toilets of the 21st century? What is the space that government public health can do best? And what is it that, other partners, other sectors may be able to do better? And how do we construct a social movement that kind of reignites and builds this culture of health? Because when we think about, again, maybe going to more of the negative side, but when we think about the fact that we're losing ground in life expectancy, we have these tremendous inequities and resulting disparities. How are we going to get through that unless we kind of shift this model and shift how we're approaching things? So it's one of those times that I think we have to be at our creative best.
Thank you, Paul. Ed?
Paul, Eduardo Simões with the School of Medicine at University of Missouri. You described so well, summarized the ACA. And I had the opportunity to actually read more in depth of that huge document. I didn't read the whole thing. I just read summaries of summaries of summaries. At any rate, it's pretty obvious there that they give us an incredible opportunity. For the first time, the health system that exists in the federal view, which is CMS, becomes the largest payer of healthcare, individual level healthcare, not our health, individual level healthcare. Therefore, they're demanding physicians and hospital systems for the first time to care and to worry about things that we always worry in public health for many, many years. So starting in April of 2014, they're going to start penalizing health systems, not bringing that money left on the table if you're not for profit, or the profit that you need to make if you don't care for population health, especially preventable hospitalization. How do you think we should partner with the private sector, one, with a medical care delivery system, because it's also almost like a little independent system. Because in the eyes of the public, for many of you may not know, but the public doesn't distinguish between public health and medicine. They don't know it. They think it's health. They think we're all nice and together. But once you start working in a medical school like I did many times, or in a public health school as many times, you know, you can see the huge divide between the two camps. Now, we are offered this opportunity in which the federal government, the largest payer of health insurance in America now, is demanding physicians, health system, to worry about population health. And guess what? They have no idea where to go or how to do it. A few do. Do you see opportunities for us here, Paul?
I do, and I think you hit on the right thing, that at this moment in time, with the economic incentives, I think where health departments need to start the conversation is reaching out to healthcare providers, and particularly hospitals, and say, how can we help? Okay, and what we have to offer is our rootedness in communities and the opportunity to build connections and linkages. It's not necessary for health departments to stand up brand new, let's say, congestive heart failure case management systems, as much as it is to really work on the community level to really say, okay, what are the dimensions of this problem? What do we know about resources in our community? How do we build these linkages and kind of make those connections? And it's through that process of building these connections and building those relationships that then we get to the next level, which is really looking at some of the opportunities for resource sharing, whether that starts with community benefit, or if it starts with looking at ACOs or CCOs or other opportunities that might create new ways of doing financing. But the relationship, just like we learned in the early 2000s around our role in emergency preparedness and disaster response, public health bought a seat at the table because there was a whole bunch of new funding. That's not true. And you know what? Buying a seat at the table didn't really sustain anything. We had to develop those relationships and go into practice side by side with first responders and emergency management agencies and earn that relationship of mutual trust. And now that's the ground that we've gained. And so I think we have to take that experience and apply it to the new challenges that we're facing with chronic disease and the changes in health reform.
One more question. Paul?
Paul, thank you so much for what I think is an inspiring opportunity for us to reimagine public health. And you've laid out a number of dimensions which I think have great implications for the future. And I wonder, since many of us, in addition to doing research, are also focused and interested in workforce, what do you think are some of the implications for our schools of public health and our programs that train new public health practitioners? What advice would you give as you talk to those of us who are developing new practitioners to enter your new reimagined public health world?
Well, I think there's going to be a series of presentations on workforce, and I hope that we can continue this conversation. But I think what's critical is that we really look at bringing this to the frontline public health worker, be they nurses, sanitarians, health educators, and expand and reconnect around this role of community-focused practice so that I don't just think of my role as a public health nurse as taking care of a caseload of families, but I really see that as a connecting point with a broader set of community issues. So again, we can go back in either public health nursing or in public health sanitation and see that when those professions were really being developed, there was this much larger community focus and population focused practice that had an element of practice in an aggregate level and really thinking about policy and advocacy and those kinds of things as part of the role. And so I think those are the kinds of things that we need to revisit, and we really need to look at how do we build the skills that people need to do the convening, to do the linking, and all of those necessary elements in these new roles. So it's a huge order. I think it's something that should keep all of you in public health education busy for the next 2 or 3 years. So.